tanya pasal nephrotic punya definition, you also bagi yang lama punya definition. What's the new definition nephrotic? From KDIGO guideline latest. Kenalah update. The definition still sama, but there is some yes, but there is some change in the cut-off values.
Yeah, the albumin now is less than 20 for
No lah, less than 30 kan? Less than 30 now. Yeah.
That's the demand lah.
Dan the urine spot PCI itu sama jugalah, still lah more than 200 millimole per liter lah sekali. So kalau you all nak classify nephrotic syndrome, macam mana? Okay, based on etiology.
Then actually usually we have to do a biopsy.
Okay, so based on what you know tu, apa the etiology?
I know like the minimal change.
Yes, that's one number one. Minimal change disease. Lagi?
IgA also
Can, but very rare in children lah. Apa lagi more common, a bit more common? FSGS lah. Focal segmental glomerulosclerosis. Lagi satu?
Ada mana dia tengok minimal dan FSG.
Ya. Okay,
There's one more.
membranous. The main thing you as general pediatrician, when managing your children datang with edema first time, undiagnosed nephrotic apa ke lah, then you don't know this one steroid responsive, steroid sensitive. What are the features? The atypical features apa?
Which came actually with hematuria.
Yes, that's one. Some gross hematuria. Yes, hypertension. Okay. Lain satu? Lah, but other features tu maybe from investigation lah, like low complement level ke apa. Yes, kalau minimal change disease, they won't have low complement lah. If patient got SLE ke, post infectious strep whatever, can boleh jadi low complement lah. Alright. Yeah. And then another thing, the age no, less than 1 year old, more than 10 years old. Those are the other typical features. Okay. So if you talking about hypertension, so what is the basically the, I wouldn't say pathophysiology, the theory behind it. Okay lah, I cakap straight away. What is the underfill theory and overfill theory? That we explain why certain patient got hypertension. That the one yang bukan typical nephrotic syndrome. The typical nephrotic syndrome, they will have underfill punya mechanism.
But the atypical is overfill.
Yes. So explain.
I know the concept, but I to put it in words, I need to read up. I know the concept how it works.
I don't know lah whether this thing gonna be asked or not lah, but at least you know.
So that's how sometimes we start down on the potassium sparing agents.
Okay, so the typical nephrotic syndrome, you have your loss of albumin through the urine protein losses, then you get fluid shift from your intravascular into your tissue, right? So you become under volume per se lah. So that one will activate what? Your RAS, your renin, aldosterone, angiotensin system, your ADH semua betul lah. Then akan lead to sodium retention and water retention. So because of fluid shift tu, you get very edematous lah. Okay. So that's why this underfill lah, sebab volume become less because of fluid shift. Why overfill? The mechanism is a bit different lah. So you don't have that albumin losses per se, but you have more of like changes in the tubular changes. So you retain sodium and then you retain water lah, because of the defective this tubule punya defect problem lah. This can happen in all this steroid resistant punya FSGS punya problem lah. So when you have so-called no volume loss, you kind of have no more volume or over volume, so you become overfill lah. That's explain that hypertension. Okay, so the treatment from these two punya theory is a bit different lah. That's why kalau patient yang hypertension, you don't give albumin, and then you bagi typical punya treatment, you give albumin. Kalau under volume, then you bagi Lasix kan to support. Kalau you bagi albumin 5%, something like that, then you might overfill it some more, so they are at higher risk of developing pulmonary edema lah. So lagilah teknik on top of kalau dia perlu refusion ke apa. So the straight away treatment punya tu is always furosemide straight lah, Lasix lah, diuretics. So diuretic. So that's why you punya steroid resistant tu ada amiloride, ada Lasix. Okay lah, albumin tu kalau dia tak hypertension lah, hypertension I wouldn't even give. Okay, you tahu dia sangat volume very risky lah untuk pump hypertension. So kalau you dapat patient first time datang hypertension, BP high like that, walaupun tak diagnose lagi, given that dia ada hypertension pun, probably you kena treat hypertension with Lasix, sebab probably dia overfill. So even though dia ada AKI pun, macam urea ada 11 ke apa ke, you still bagi, sebab
you want to reduce
the volume. So some people, when you in the position, you have to make decision, you tengok urea tu 11 and then you nak bagi ke tak nak bagi urea, you takut lagi dia naik some more. But for nephrologists, they don't really care about the urea punya volume, they really care about patient is overloaded. So don't chase the number, you treat the patient lah. This is basically just from my experience. Whatever I'm telling you is the one I have done. I bagi hypertension bagi.
Then they don't give boluses, they start low dose IVI, and then they see how the function goes. Because they can still PU, that's not the problem. It's just that the urea fat are high and hypertension, so they just want to play with the volume.
As about changes in KDIGO guideline in term of managing nephrotic syndrome. Dulu, if in term of treatment duration, I'm not going to ask specific treatment berapa lama, initial therapy apa semua tu lah, you all should know lah. Tapi any changes from the previous punya regime now to the latest punya regime, this thing akan masukkan dalam new protocol nanti.
Yang definition remission tu.
In term of initial therapy tu still sama, you bagi 1 month steroid, 1 month punya alternate therapy, itulah remission punya therapy. For frequent relapser, there are a lot of changes. Okay, because the main point in the latest KDIGO guideline is to reduce steroid burden. You don't want to overload them with steroid all the time lah. Sebab previously, you bagi frequent relapser, you taper over 3 months, 6 months. So now they don't want to do that. So you still treat them as per usual. You bagi steroid during induction, remission you change to remission punya regime, and you off it after up to 6 weeks paling lama. Okay, then you don't taper macam tu lah. Okay, but in old punya tu kita taper sampai 3 months to 6 months. But I think the study show after 3 months dia punya tu, if they want to relapse, they akan relapse juga. Tak kisahlah you maintain a low dose ke tak, they will still relapse. Okay, so the aim of to reduce steroid burden. Another thing, how they reduce the steroid burden tu, from EOD punya regime tu, you daily kan lah. Kalau contoh patient having intercurrent illness, tak sihat pun, EOD tu EOD kan. That one pun they don't advise, they don't recommend anymore. Okay, so those are the methods lah how they want to reduce the steroid burden lah in the latest KDIGO guideline. On top of it, the recommendation to basically how soon we want to use steroid sparing agent lah in frequent relapser ni. I think the frequent relapser lah yang paling banyak steroid burden kan. Sebab how soon? Yes. So you want to reduce steroid burden tu kalau too frequent of relapse and then steroid dependent after 2 weeks.
The guideline, but clinically what I've seen is if the patient relapses more than 3 times in 6 months, then
So kalau those yang ada steroid toxicity tu no brainer lah, for sure you go steroid sparing agent. But those yang haven't steroid toxic yet but somehow a bit dependent on steroid after 2 weeks off ke apa ke, those another candidate lah. Another thing pun, you probably yang frequent relapser ni pun probably you need to offer parent juga and patient jugalah ada agent yang available so that they want to avoid the steroid toxicity itulah sekali. Those are basically the thing lah pasal yang KDIGO latest guideline tu. So why less than 1 year old more kena buat renal biopsy kalau datang dengan nephrotic punya syndrome?
One, because it's unusual.
Yes. So what disease we are looking for? That's less than 1 year. What is the primary cause of nephrotic syndrome? So congenital nephrotic syndrome, apa genetik punya issue? pernah dengar finish type tu? Dia genetik punya isu lah, finish type, and HPS1 punya gene mutation causing congenital and infantile nephrotic syndrome lah.
Okay. I've never seen one also.
No, it's probably pada undergrad, you go undergrad tu probably they have put this in also juga, put lah. Probably you ingat tak ingat je, congenital nephrotic syndrome.
Ada actually one of the patient nama dia Princess.
Yeah.
Rockamila punya Princess.
Dia congenital, infantile.
Indonesia.
I see.
Sayang je.
Princess.
So ada causes could be messenger sclerosis, could be yang podocyte punya problem lah, podocytopathy or something like that. Dia WT1 gene dia yang associated dengan Williams tumor tu. That's why kena buat renal biopsy lah. And then kalau more than 10 year old, explanation dia apa disease more common in more than 10 year old?
Usually like they come with associated issues, not like SLE, that kind of thing.
Secondary lah. Secondary lah. SLE. I think the etiology pun you kena tackle lah. The primary tu pun kena include secondary lah, which is your HIV, Hep B, Hep C, CSLE, whatnot. More than 10 year old more likely to have other problem secondary causes, and then the primary causes dia FSGS probably more common kot. Lah compared to yang sebab 1 to 10 years old minimal change disease is most common lah, but not all minimal change disease is steroid sensitive. Sekali actually all the steroid resistant I seen all minimal change. I jarang gila jumpa FSGS. Maybe one of the
FSGS they respond very well with Mendoza, and then they can maintain.
Yes, but those yang renal transplant tu was FSGS lah sekali.
I think in HPP all the kidney transplant patients we have, one is doing very well. The other one also issue came back, started relapsing.
The thing is, if you primary tu memang primary cause tu memang FSGS for example, the FSGS can reoccur even though that one is from the kidney punya, sebab you punya gene is still there what.
Yeah, because the donor was around.
Yeah. So certain thing yang macam nephrotic syndrome yang dok recurrent ni pun, even if you go for renal transplant pun, the likelihood for it to happen pun still there, quite high. One thing, unless memang primary causes renal punya failure is because of some other thing. So contoh so kalau polycystic kidney disease tu a bit more better prognosis kot. Kalau yang steroid resistant ni they will likelihood they will recur.
But ESRF jauh sikit. But nephrotic after they are resistant, try multiple second line and end up with.
ESRF in children most common is always steroid resistant nephrotic syndrome lah, tak ada benda lain lah sekali. Anything else lah pasal nephrotic? Entahlah.
Banyak.
Juga.
Nephrotic, one of the common question.
Exams.
Long MBQ.
Sekali.
Rockamila ada banyak gila soalan long MBQ pasal nephrotic yang dia boleh
buat. Soalan long MBQ dia tak straightforward sangat, tak senang sangat, tak susah sangat, tapi in the end how you salah jawab. Tak ada knowledge tak boleh jawab. But most of it is always based, our long MBQ is all based on the patient. Tak ada pun patient tu make up punya patient, tak, it's always based on revision. One thing, sebab based on revision paling senang how we want to think the question. Kalau tak susah nak fikir soalan. Sebab tu dia clinical based, dia punya exam ni, it's not very not pure theory. Sebab tu lagi banyak tengok patient lagi bagus. That's why ada pass over petang tu, even though you on call ED pun you still have to go. Sebab that's the only time you see ada ward punya patient. That's what I did. Even though I on call ED regularly pun, I still follow around from A to Z, sebab that's the time you tengok patient, that's time they pass over the important part what to look for. So those things, but they akan translate to your exposure, dia akan translate you punya knowledge jugalah to certain extent. Kalau you baca lagi banyak lagi bagus lah, but exposure tu penting. Sebab kalau you tak expose to you a lot of condition dan you tak pernah tengok basic condition ni waktu exam, macam mana you nak jawab? One thing. So those are basically why we important pass over round petang tu.